So hello everybody, my name is Michel Boisiers. I'm a vascular surgeon working at the University Hospital in Bern, Switzerland. The topic we're going to talk about today is the 5-year outcome of the ZILVERPASS trial, which is a trial comparing the Zilver PTX drug-eluting stent with prosthetic above the knee bypass in TASC C&D lesions. So we know that peripheral arterial disease is on the rise, and a lot of patients are being treated endovascularly, despite the fact that the TASC 2 recommendations stated back in 2007 already that TASC C&D lesions should be treated with open surgery and bypass surgery. But in the recent years, a lot of trials have come out which showed that actually endovascular technology works, especially when we're using drug-eluting technologies. And so we wanted to see if the Zilver PTX, so drug-eluting stent, would fare against prosthetic above-the-knee bypass surgery. So we evaluated 220 patients, which we randomized in a one-to-one fashion to the Zilver PTX group or to the bypass group. And we included patients with Rutherford stage 2 to 5, so not only claudicants but also CLTI patients who had a de novo lesions in the femoropoliteal arteries, which would be at least 15 centimeters, so TASC C&D lesions. But the early outcomes were that the 30-day freedom from complication rate was significantly better in the Zilver PTX group, where we had a 95.6% freedom from complication rate after 30 days compared to 88.7% in the bypass group, mainly due to the fact that standard complications for endovascular therapy are bleeding at the punctured site or hematomas, where in the bypass group you have infections, wound healing disorders, lymphedema, etc. The long-term data that we now have is that after 5 years we have no significant difference regarding primary patency rate, which is about 50% in the Zilver PTX group and 40.7% in the bypass group. Also, freedom from TLR after 5 years was equal in both groups, so 63.8 in the Zilver PTX group compared to 52.8 in the bypass group. Looking at survival of this patient cohort, we also saw no significant difference in both groups. Zilver PTX, 49.3% survived after 5 years. In the bypass group, it was 40.7%. We also looked at the freedom from amputation rate after 5 years, because we also have a group which was CLTI patients, and we had a 94.6% amputation freedom with the Zilver PTX group compared with 92.5% in the bypass group. We performed a sub-analysis looking at claudicants versus CLTI patients, but also there we found no statistical significant difference. I think the take-home message after this study is that for TASC C&D lesions in the Fem-pop arteries, that at least the Zilver PTX has a non-inferiority compared to prosthetic above-the-knee bypass with similar patency results, but having less complications and shorter hospitalization stays from around 2 compared to 8 days. For further studies, it's going to be important that we look at on the patient level, which patient would profit more from endovascular therapy and which patient would profit more from open surgery, and then maybe with venous bypass. But as we know from the BEST CLI trial, at least 20% of all patients don't have an adequate vein to use for bypass grafting.